Okay. So I'm Megan, this is my coworker Allison. We work together as nurses, and I'm going to be giving my PowerPoint presentation on preventing pressure ulcers in a high-risk patient population, which our patients are hospice patients, so they have a lot of the risk factors present, so they're going to be considered high risk. And it's I used evidence-based practice to support the data in this presentation, okay? So the abstract is this PowerPoint is going to provide education on what pressure ulcers are, how they form, the root causes, as well as explain risk assessment and staging tools, and finally we're going to explore strategies for prevention, affecting change, and implementing a protocol for prevention. That's what we'll be going over. So an introduction to pressure ulcers. What is a pressure ulcer? So a pressure ulcer is an area of localized tissue damage over a bony prominence caused by reduction in blood flow to the area as a result of pressure. So it's going to be these areas, any pressure ulcers or bony prominences. That's where you commonly find them. We see them all the time back here on the sacral area, your hip bones. Those are really common areas for pressure ulcers to develop. Next, so continuing introduction to pressure ulcers, some of the risk factors. So a Braden scale is most commonly used to assess risk for pressure ulcer development. And the risk factors will include sensory, moisture, activity, mobility, nutrition, and friction. So within these categories, like sensory is going to be how well a person can kind of communicate or can sense the environment around them, what's going on, and pain, pressure, things like that. How well they can sense those things. Moisture, the level of degree of moisture if somebody needs their diaper changed, or how often they're exposed to moisture and the frequency of that. So within these categories, it's given a numerical ranking from 1 to 4. And I actually have, if you want to look at the Braden scale, I pulled that up. So again, so for like activity, number 1 would be bed fast. That would be somebody that is completely bed bound, and it moves up to score 2 would be given to somebody that is in a wheelchair. 3 is somebody that can walk, and 4 is somebody that walks frequently and is very mobile. So the highest score, I think, is a 23. At the higher the score, the less risk factor is present. So a lower score, I think, is more risky. Okay, so 1 to 4. And again, the Braden scale is used to assess risk for development of pressure ulcers. So I think it's important to emphasize for pressure ulcers, providing education and recognizing what a stage 1 is. So pressure ulcers are staged using a 1 through 4 scale once they develop. So the Braden scale is to assess risk factors, like if they're at risk for developing the pressure ulcer. The staging scale 1 to 4 is if one has already developed. Okay, and unstageable ulcers are ones that are covered by eschar or slough. I just kind of don't know what might be under there, but they're unstageable. Okay, and a stage 1 appears as a change in color, consistency, or temperature of the skin, but the skin is still intact. So you see a stage 1 is going to be an area of redness, and you kind of push on it, and it won't be blanchable. So when I push on my skin and it turns white and then it goes back to its normal color, that's blanchable. So when there's a stage 1 present, you can see it's red and you push on it and it won't change color, and that's the first stage. So I think it's important to recognize that for what it is, because at that point, if we can intervene at that point, then we can obviously prevent further development. So recognizing a stage 1 and providing education, I think is a really important intervention for staff and providing patient care. So early recognition of the problem may allow for early intervention and further prevention of further deterioration and skin breakdown. Okay. the cost and financial impact, so estimated cost annually is $9 to $11.6 billion. Individual patient care cost is $30,000 to $150,000 per pressure ulcer. So that sounds like a lot of money, and that's that's a wide range. So there's a lot of factors that probably come into coming up with that estimate or that range. And I think some of it has to do with obviously treating a stage 1 is going to be less expensive than treating a stage 4. So that's probably where that comes into play. But it's very costly. In 2007, Medicare estimates over $40,000 in additional costs in hospital stay related to pressure ulcers. And in 2008, Medicare and Medicaid instituted a policy that reimbursement would not be made for pressure ulcers acquired in acute care setting or hospital. So I'm sure most of us are familiar with that. So there's reimbursement is not made for pressure ulcers that are acquired after a patient is admitted. And one of the rationale for that is it's something that we as healthcare providers, that we are very instrumental in helping prevent those things. It's very, we have a lot of impact on that, and I'll get to that in a minute. But they do not reimburse for hospital-acquired pressure ulcers. Objectives, what do we want to accomplish? So through this PowerPoint, we want to provide education about pressure ulcers. We're going to provide strategies for prevention and implement a protocol for prevention using evidence-based research and guidelines. Okay, so that's what we want to accomplish. The rationale of why do we want to accomplish the objectives? Pressure ulcers place an enormous financial burden on the healthcare industry, and we kind of went over some of that. Prevention is far less costly than treatment, according to research and analysis conducted by Barbara Braden. She's a nurse, I think, in the industry. Now she works with the National Pressure Ulcer Advisory Panel. Estimates through her research that the daily cost of prevention was $54.66. That would be the daily cost of prevention. The estimates of daily cost of treatment is $2,770. So again, the cost of treatment, there's multiple things that go into that, how far along the ulcer is, but you can see what a difference in cost that is for daily prevention versus treatment. So pressure ulcers lead to poor patient outcomes, including pain and discomfort and an extended length of stay in the healthcare setting. So those are some of the reasons of why we would want to address and accomplish the objectives. Okay, some of the root causes of pressure ulcers. Pressure ulcers result from a decrease in blood flow to tissue over a bony prominence, here, ankles, your backbone, causing tissue death and necrosis. This is what a pressure ulcer is, but I think there are some of the other root causes would be understaffing. That's very common to have, just a lot more patients than there are caregivers available to those patients. Just a very limited number of resources. Perception of more impending problems or visible issues that require immediate attention. I think prevention is ignored, thus leading to more problems. And I really want to put emphasis on that. I think it's really important. I think people's perception, and it makes sense to me if you have something immediate or a task that is right in front of you or a problem that you see it demands immediate attention, you're going to address that rather than taking measures to prevent a possible problem. I think it's just human nature. For example, driving down this road, I see that maybe if more was invested in infrastructure and keeping up with the roads, might be more cost effective than going down the road. There's potholes and things like that. You go back and fix it after it's already become a problem. So I think it's kind of similar. People aren't inclined to address something until it becomes a problem rather than preventing it. And there's no education or training for risk assessment or use of scaling tools. Of course, I think everything begins with proper education and training, and again, a lot of that might be due to lack of time or funding, staff, those kinds of things. or maybe just not enough importance is put on it. I'm sure since 2008 and Medicare made that decision to pull back on the reimbursement, I think probably a lot more attention was given to addressing that problem. So lack of education for patients and families. I never want to assume that patients or families know anything, even if they've had the issue before. So I think it's really important to take the time to whatever you're doing for them, to educate them not on what you're doing, but why you're doing it. So I think the why is just as important as what you're doing. So lack or underuse of prevention equipment or devices. So an example of that would be like an APP mattress, and there's many times where I've gone into a patient's room in their home and they have the APP mattress and everything's all set up, but it's not turned on. I mean, that's something that's almost so simple that you just wouldn't think to tell somebody, but I just never assume what people may or may not know, and they think it's not working. Well, you got to turn it on. You have to show people this is how this works, and the settings adjust. Okay, if you don't like this setting, try a different one. But just very, very simple things that I think get overlooked. So, and that equipment is very important. It's specifically to alternate the pressure in the bed for those patients. So just some very simple things that could be addressed. So the Peacock question: in a high-risk patient population, how does various turning and repositioning schedules reduce pressure ulcer occurrence over the course of 6 months? So the P is the high-risk patient population. Various turning and repositioning schedules reduce pressure ulcer occurrence over the course of 6 months. So let's see, we have the intervention, turning, repositioning, the comparison, how it reduces the pressure ulcer, the outcome of reducing the incidence, and the time would be tracking that over the course of probably 6 months to a year. Okay. So the solutions: education and in-services provided to staff involved in direct patient care. So CNAs, nurses, anybody that has hands-on care, family members, maybe even the patients themselves. Scaling tools, like we went over the Braden scale and the pressure ulcer scale, the 1 through 4. Education provided on those things. The DME would be the durable medical equipment. What it is, why we're using it, like the pressure ulcer mattresses or the APP mattresses, heel protectors, things like that. Just putting an emphasis on not just how to use it, but why we're using this, why it's important. Skin assessment and recognition of early stages, as well as turning and repositioning schedules for prevention. We want to emphasize the importance of early reporting. Again, and some people may not recognize that stage 1 for what it is. It doesn't look, it may not look like something that needs to be reported. But yeah, the earlier that's recognized and can be reported, because those things, pressure ulcers can get really bad really quickly. So if you can catch it in that early stage, that goes a long way. Education for patients and families to help prevent pressure ulcers. So again, just taking the time, writing things down. I find that you do have to ask families, to repeat things back to you, whatever kind of education you're giving. They're taking a lot of information. They're overwhelmed, and when you're in the home care setting, it does help to write things down and to just go back over it again, or tell them, ask them to demonstrate, or if they have any questions or what they understood. Because I find when I do that, they might have heard something totally different. I often have to go back and go back over something, which is fine. So the solutions, again, for prevention, turning and repositioning is one of the interventions that I chose to focus on, and there is a lot of evidence-based research and data that I collected and looked at that supports the turning and repositioning, and I don't think that that's anything that is very surprising. Pressure ulcers caused by pressure and staying in the same spot. Obviously, turning and repositioning is going to help that. It almost seems self-evident, or but I think sometimes having the intervention, there might be different ways to implement it. So I think that is worth looking at too. Okay, here's the intervention, turning and repositioning, sure, but what can we do differently, or how are we actually going to implement this so it's successful. So I think, let's see, so repositioning 2-hour intervals, research and multiple articles that conducted randomized controlled trials support turning and repositioning to prevent pressure ulcers. So again, it is supported through the evidence. So we want to create specific turning and repositioning assignments for patients identified as high risk, and that's pretty much everybody that's in hospice and home care. So having specific assignments and schedules and individuals that are accountable. So and I think that makes a huge difference. So assignment sheets, I think, will help hold the accountability, signing in, signing out, and keeping that communication between providers, having the same person caring for the same patient, kind of having that continuity of care. So designating specific team members to monitor pressure ulcer incidents and evaluations. So, once we implement the scheduling and the assignments and the paperwork, having specific team members like myself that will kind of track over an extended period of time if this is working and the incidence has gone down, and evaluations of the CNAs in the home, so we can evaluate the task and kind of redirect or demonstrate as needed. Okay, so I think that's important, not just telling somebody something, showing them how to do it and following up. Okay, again, durable medical equipment is very important, identifying patients that would benefit from the DME. A lot of those are going to be your bedbound patients, so again, things like APP mattresses, gel mattresses, and discussing those, the benefits of those with patients and staff. Providing education, providing instruction and demonstration on how to use the equipment, and I think we talked about that earlier. And how do we affect change? So all of this sounds really great, and it looks, in a PowerPoint and reading it and going over these things, it's obvious that it's really important, but how do we actually affect this change? We know that it's important, we know that the evidence supports turning and repositioning, but how do we implement this and get people on board with this change? Because I said nobody likes change. Most people don't. I don't like change. I get used to and comfortable, right, with the way you do something. You're like, I don't see why it's the old way is just fine. Why do we need to do something different? Especially when it comes to things like prevention, you're not necessarily seeing, if you're preventing something, you're preventing it. So you're not seeing the problem. It comes from data that comes later. So the immediate reward is not apparent. So I think sometimes people kind of get lost in that. Well, is it really making a difference? They don't, we're very, or at least I am, like to see the reward right away, that instant gratification. And prevention protocol, they're not necessarily like that. So it's important to provide education on why something is being done, and I think I've said that a few times. I think that's important. Why something is being done in addition to how to perform a task. So I want to involve staff members in the process and get their feedback on, if they think it's a good idea or what they think they can contribute, or their experience, or just their feedback, questions, anything. I think people are more likely to participate in change if they believe it will be more beneficial to themselves and the patient versus, again, the old way works fine mentality. So yeah, for sure, if people perceive that there's going to be a benefit to themselves and the patient, I think they're more likely to participate. It's going to make your job easier in the long run, so on and so forth. So I want to monitor and track this over, an interval of 3, 6, 9, and 12-month period, and just kind of collect the data and see what the incidence of pressure ulcer occurrence is compared to with previous data. I think quarterly in-services on skin assessment, risk assessment, the scaling tools, staging, and durable medical equipment use is important to kind of reinforce education, questions, and those things. And then again, CNA reviews, just going back in and taking the time to meet your CNA in the home and kind of get hands-on demonstration and evaluation right there instead of just explaining a task verbally. So the outcomes that we hope to achieve: reduction in pressure ulcer incidence, of course. This will increase patient comfort and quality of life. So by eliminating or reducing pressure ulcer incidence, this also will eliminate secondary complications that would include, most obviously importantly, especially for hospice patients, would be pain. That's a priority for us, as we want these people to have, be as comfortable as possible, and they have a quality of life too, and they deserve that. It prevents local infection. Anemia can be secondary to these things, sepsis, and osteomyelitis. So those are some of the things that can occur secondary to pressure ulcers. So if you eliminate that, you can eliminate all these things as well. That would be a fantastic outcome. Again, very costly. So it's going to decrease the cost related to supplies. Again, for treating is a lot more expensive. Just the sheer cost of supplies and time and manpower to treat pressure ulcers, from my own personal experience, is staggering at times, because they can be resistant. Okay, so my personal obligations. I included this quote. In 1859, Florence Nightingale was quoted as saying, "If he has a bed sore, it is generally not the fault of the disease, but of the nursing." And I said, Nightingale's quote may be a bitter reality to face, but also an empowering one, as nurses have the ability to affect change as caregivers at the bedside. So when I read that, it kind of makes me feel that twinge of like just a little bit of guilt, because we don't want to think we're doing the best we can for our patients. But again, I mean, there's reality to that. Bed sores that occur in the hospital or in the home, or that has something to do with there's something being missed there, something not being done or overlooked for the patient. That again is probably very as simple as turning and repositioning every couple of hours makes a huge difference. So those things occur from people maybe not being as diligent in their work, or following up, reporting to the nurse when they notice those stage ones, or maybe they don't recognize it, and some education. So there's a miss there somewhere that does go back to might go back to the CNAs and nurses. But again, on the flip side of that is because we are the people right there at the bedside, we have the opportunity and kind of empowered to make that change. So I think that's a good way to look at it. I feel kind of empowered that I can make this difference, specifically as a nurse. So obligation, and I have obligation to use the evidence-based data to support the interventions and promote the best outcomes for patient, leading to patient RN satisfaction. Again, not just using guesswork, or I think this has worked before, maybe let's try, went through and did the research that supports the turning and repositioning schedules. There's been numerous trials and clinical research that supports that. It's not just based on my anecdotal experience or experience. Is based on thorough research. So I think it's important to implement that. So in summary, pressure ulcers are very costly. They lead to poor patient outcomes that we went over, and the evidence-based interventions such as turning, repositioning, the turning and repositioning assignments and schedules given to staff will be implemented along with in-service training, demonstration, the staff evaluations, quarterly tracking of the effectiveness to decrease incidence of pressure ulcers, and ultimately to improve our patient outcomes. And that is it. Thank you. Okay. Thank you.